Hey guys, this is Terry. I'm ready for my final presentation. I don't know about you guys, but I'm kind of glad to be doing this because the more I would look at it and read about things, the more and more information I found that I thought was interesting and to put into my final information. So it kind of just went on and on. But hopefully this will be helpful to you. It's something I've found really interesting as far as seeing in clinic. It's Takotsubo cardiomyopathy, which is also, I think, more well known as the broken heart syndrome. I remember seeing a movie as a child uh, about someone losing their boyfriend or something. They had died, and um, the girlfriend ended up passing away because she was just brokenhearted. And I remember that kind of left an impact on me, but didn't really know it was a real thing until last fall when I was in Branson and saw it in the hospital there. Um, so it's very interesting. Hopefully you'll find it interesting too. So this tells a little bit of a history about the Takotsubo cardiomyopathy. I may call it broken heart syndrome or TTC, just for short. A little bit about that. It really looks like a heart attack or a myocardial infarction in clinic. So when you first see it, you may think that's what is going on. It has the ST segment elevation on the EKG. And you really don't know till later on that may not actually be a heart attack. It's the Takotsubo. So it looks like a myocardial infarction, but without the coronary artery disease or blockage. Um, it's precipitated almost all the time by physical or emotional stress and acute stress of some kind. It's rare, less than 200,000 cases annually in the United States. That still seems like a lot to me, but I guess it could be worse. Discovered in 1990, was named after the Japanese octopus trap, the Takotsubo, right there, because that's what the heart resembles. That's an X-ray, and it resembles the octopus trap pot or Takotsubo. So that's where it got its name. I did see cases where actually there was a lady in 1986 in the United States that had presented with these symptoms. I guess we didn't claim it as the initial case or finding of Takotsubo or name it, whatever it might have been named if we would have, you know, shared our discovery or something. I don't know. But somehow it just saying, most of what I read was that it was in 1990 that it originated. But I did see cases earlier than that was mentioned. So my case that I saw in Branson last fall was a 73-year-old female. I didn't actually get records on this lady. I had a hard time with that. So my information is pretty limited about her in her outcome. We treated her at Branson with an LVAD, left ventricular assist device, or Impella, which I've never heard of that either. It was really cool. They compared it to a little jet ski motor, how it just kind of revs the blood through and allows the left ventricle to rest. So that is the main thing I remember with her being treated. They were just trying to let her heart recover. She had just had a recent surgery, nothing related to cardiac, no history of cardiac issues, but she presented with chest pain, typical signs of a heart attack, but that's not what it was. So we stabilized her as much as we could, and she ended up going to Springfield to a larger facility, and hopefully she was okay. So kind of going into this, again, it was for the most part discovered in 1990, named after the Takotsubo or octopus trap. It's characterized by reversible left ventricular contractility dysfunction. So some wall motion abnormalities in the left ventricle, typically like the apex and the mid ventricles are akinetic. They're not moving, and then the basal region is hyperkinetic. So that's primarily what you're going to see. And you get what's called apical ballooning. So the basal or the apical part of the heart is just really round, not contracting at all. It just stays large. It occurs primarily in postmenopausal women. So not to be negative, but another reason, I guess, to be happy about being a woman. But it occurs primarily in almost my age group and older, precipitated by stress, physical or emotional. Could be lots of different stressors. It's also known as the broken heart syndrome, transient apical ballooning syndrome, apical ballooning cardiomyopathy, stress induced cardiomyopathy, or just stress cardiomyopathy. So I'll let you guys write down notes if you need to. What does it look like? Here's just some still TTE echo images. So this is actually showing during the acute phase of the Takotsubo, where, as you can see, the apical region over here in systole is just not contracting, it's not moving, it's kind of staying out. And then later on, after its recovery phase or after the patient starts improving, it goes back to the normal contractility here. So it's got some hypertrophy, but still you see it's contracting pretty well. So that's kind of what you'll be seeing if you see it later on down the road. Symptoms, it's really going to look like a heart attack again, or a myocardial infarction. You're going to have maybe shortness of breath and chest pain. Those are the most common symptoms that are going to present. Other symptoms can include palpitations, so that heart fluttering or fluttery feeling in your chest, kind of some abnormal beats you may be feeling, nausea, syncope or dizziness, lightheaded, fainting, or cardiogenic shock, which is just your heart's sudden inability to pump out enough blood or meet the body's needs for that blood. So it just kind of happens all of a sudden. Again, it mimics a myocardial infarction without coronary artery disease or obstruction. The EKG will show ST segment elevation, like a heart attack. Excessive catecholamine substances in your body. So these would be what are produced during your stress times or the fight or flight episodes. So epinephrine, dopamine, adrenaline, those levels become really high suddenly. So maybe one of the things you're seeing with Takotsubo. I read that there was a circadian rhythm relevance to this. So that would be like your daily kind of body schedule, morning waking up, night going to sleep, that kind of thing. I saw conflicting information. Some studies said that it was more common in the morning because your stress hormones are higher. I don't know about you, but if I'm stressed about something, I kind of wake up in a panic 3 o'clock in the morning, that kind of thing. So I saw that, but then I also saw that the morning stress, excessive amount of hormones are related more to an actual cardiac event than Takotsubo. So Takotsubo normally or more frequently occurs later in the afternoon, like when things actually have a chance to happen, as far as a bad event, something stressful, something like that. So conflicting information there. There was no hereditary link with this. I did see that it occurred less in African American population and Hispanic populations, and 2/3 of people that present with this have had some sort of stressor or a neurological or psychological disorder. Who gets it and how? Again, primarily it's postmenopausal women. Can occur though in any sex at any age, so it can be males, it can be younger. I saw studies with people in their 20s or so, and that's mentioned here later on. So most of these are even more specific to an age range of 65 to 70% of women, or 65 to 70-year-old women. That occurs 85 to 90% in those age ranges. Documented cases that I saw, kind of interesting. A 38-year-old female had Takotsubo after a Zumba class. Another 38-year-old male was like 6 months post-surgery of just like a leg surgery, and he developed that also. Otherwise, normally healthy people presenting with these. So, and the cause of Takotsubo is unknown, but it may be due to the sudden increase in those levels we talked about, the catecholamine levels, which stuns the heart. I also did see that with coronary artery disease or obstruction, if you have a heart attack from that, the segment of the heart wall is going to be even more limited to that specific coronary artery that's blocked. Whereas with Takotsubo, it's a larger wall motion issue than just one coronary artery. So you may be able to, I don't know, but you may be able to see that if there's a larger segment of the heart not moving, and that's indicative of not, a typical heart attack. So that was interesting. Causes, different stressors, emotional, physical, medical, surgery, and other. So to break it down a little bit, emotional could be death of a loved one, including a pet, a surprise party, arrest of a family member. That would certainly be stressful. Fear of a terminal medical diagnosis, abuse, intense argument with someone. So that makes me curious about during this quarantine time and the frequent arguments that may be occurring because we're in closed quarters. But anyway, robbery, assault, public speaking. I remember what Jody said in class about us not having to do public speaking for this reason, and Mrs. Wendling wasn't buying that, so we still have to do these when we're in class. Physical would be exhaustion from extreme exercise. It even mentioned extreme sexual activities, cold exposure, severe pain. So if you had a triathlon or something like that, you're just exhausted. You could be at risk for Takotsubo. Medical could include opiate or pain pill detox. It can be really hard on the body. Alcohol abuse, smoking, asthma attack, a stress echo. So the medication you get from, I should have been more specific. So like a dobutamine or a medication invoked stress echo can be some relation to that. Mood disorders like major depressive disorder, anxiety, and I even saw that being on antidepressants sometimes can increase your chance of the Takotsubo, but I didn't see a lot. That wasn't just one study that I saw that. Seizure activity or stroke, surgery could be something fairly simple like an endoscopy, which is an invasive procedure. It's not really a surgery, but hysterectomy or even the fear of the procedure may bring on the Takotsubo. So it kind of varies. There's different classes of Takotsubo depending on what's caused it. So class 1 would be related to the emotional stressors, 2 physical, 2A would be secondary to physical activities, medical conditions, or procedures, 2B secondary to neurological disorders such as seizures, maybe. And then class 3 would be an unidentified or without an identifiable triggering factor. Maybe that other third of people. So what role do we play as echosonographers? Echo is really crucial in evaluating Takotsubo. First of all, it's portable. We can take our machine to the patient that may be critically ill and unable to be transported down for an MRI or a CT or something. So we can get there to them. It's also very accessible to that patient. And it's safe. So you may be doing echoes on these patients every day for days or longer. And with ultrasound, you can do that because you're not harming that patient. You're not exposing them to the MRI or radiation or anything like that. So it's safe to do those repeat echoes. And also you're evaluating lots of different function of the heart, the hemodynamics and valve function, muscle function, things you can't see all together in other diagnostic modes. I have a video, but I'll show you that later on because I don't think I can pull that up right now. Outcomes and complications. Most people recover from this completely. Could be within a few days or at the very longest a few months. They'll completely return to their normal functioning. Their heart is contracting well, their ejection fraction goes back to normal. Good. So in 1 to 3% of these cases, people do die. It's from complications related to the Takotsubo. It's not just the Takotsubo itself. And if you have it once, there's a 5% chance you're going to have it again. So most complications occur during the acute phase. So the initial phase when it's just happening, and that's about 52% of cases. Can be heart failure, mitral regurg, arrhythmias, left ventricular outflow tract obstructions, ventricular rupture, pulmonary edema, pericardial effusion, or thrombus. We're going to take a look at these different things here. So this shows the heart failure with reduced EF. This is going to happen in about 12 to 45% of the cases. It also says pulmonary hypertension may be present. So I found these pictures and it kind of just shows you, the reduced EF. I'm not sure what this person's EF was, but it is reduced. So this is the acute phase when you're going to be seeing that lack of movement in the mid-ventricular or apical regions. And then this is showing you a high degree or high pressure gradient for the tricuspid regurg, which is 41 millimeters of mercury. This is in the chronic or recovery phase. So the heart's gone back to contracting okay. Tricuspid regurg, is kind of resolved as well. So these are some echo images maybe to look out for when you're evaluating these patients. Next one is the Takotsubo with left ventricular outflow tract obstruction. That's going to happen in 10 to 25% of these cases. So here you see during the acute phase again, so it's when it's just occurring, there's some systolic anterior motion of the mitral valve anteriorly here. It's going up and it's causing the outflow tract obstruction for the mitral valve. So the flow is not getting in there, and then after it's kind of recovered, then you're seeing here it's opening up more, and it seems to have resolved itself there. This is often going to lead, of course, to mitral regurg as well here. And here is the mitral regurg. Same image actually, just is showing the hemodynamics of it, and that's going to happen in 14 to 25% of patients. So you're going to see a large portion of regurg here, and then over in the chronic or recovery phase, it's resolved itself. Pericardial effusion. So this can happen in 43% of patients for various reasons with Takotsubo. These images are from, I believe, a left ventricle rupture that had to be surgically repaired. So we're seeing that some pretty bad looking effusion here, and then up at the top over there, and then after surgical repair, and the Takotsubo has, the patient's recovered from the acute phase, you're seeing it, now a lot less. The right ventricle is expanding, as it should. That looks much better. The effusion's gone, and then it's gone up there as well. So it's a good prognosis to have, but I'm sure it's really scary to go through that, especially considering the stressor you may have gone through to bring it on. Treatment for Takotsubo, there is no real treatment known. You're kind of addressing the symptoms that are going on with it. I did see one thing mention the importance of echo, because you're monitoring all those things. You may know specifically more what the patient needs to be treated with. There was one, we're saying being treated with inotropic medications would actually increase the symptoms that they're having, where, having observed it with echo, more that they should be treated with a beta blocker, which actually decrease the symptoms that they're having. Let's see. I think that's it. And then there's my references. Hopefully that was interesting to you guys. It was to me. And I hope you all are doing well, and hope to see you soon. Thanks.